Good morning.
Good morning.
This is Miller County.
Yes.
Can you hear me?
Yes.
Okay. All right. Let me introduce myself. I'm Deborah Drummonds. I'm senior coordinator here at ABAC. I've been a nurse all my life since 1974. I don't think any of you were probably around, or maybe some of you were. Got my master's of always like critical care. My master's is in critical care from Emory. So I love blood gases. I like acute care. Let's see, I have 3 children, but that's enough about me. Do most of you, I have worked in a small hospital where there were 30 beds. It's just me back in the day, and we used to call them orderlies, to a very, very gigantic hospital like Emory. But anyway, I'm glad to be talking with you, and hopefully I can condense blood gases to make it a little bit simple. I have my email up there if you have any questions. I like talking with nurses around the state. All right, how many of you have the PowerPoint that I sent? And I sent an attachment. I sent an attachment in the PowerPoint. And I sent it this morning. If you have it, the attachment says like arterial blood gas interpretation. And it kind of mirrors my PowerPoint. So if you can't get everything down, it's on the handout. So they had to change my thing. Chris. Sorry, we had computer, now it won't move. Let's see, I guess I can, that does make it. There, okay. All right, first thing is, why do nurses need to know how to interpret arterial blood gases? The number one reason is for better patient outcomes. It didn't move, but I got to move it. I figured it out. And acute care settings, how our blood gases are done in all settings. And as you know, our patients are getting sicker and sicker and more complex. So the need to interpret arterial blood gases is very important. But on the nurse's side of it, the knowledge that you get from learning blood gases and compensation can help you if you become certified either through CCRN or CEN, certified as critical care nurse or emergency nurse or whatever certification. And one thing I have found that nurses in this area do not know how important certification is, because when you go renew your Georgia board license, you know you have to keep up with CEUs. And me being certified, all I have to do is send a copy of my certification, and that's all I have to do. Now, I know some of you may want to go on to be advanced practice. So again, knowledge of blood gases helps you if you want to do that. But just on the other hand, when you know what's going on with the blood gas, there is less malpractice. And my being certified as an emergency nurse certification, my malpractice insurance is cut $30, which every little bit helps. Now, when you want to interpret blood gases, you have to know normal. Anybody who ever does assessment knows you have to know normal. So the first thing, and I think y'all have it there, is you have to know the pH 0.35 to 7.45. And if you ever have a brain moment, can't recall something, if you know the pH, you know CO2. And I have had students who go to Piedmont, Atlanta, or even at South Georgia, and somebody asks them a blood gas. And sometimes your mind can go blank. So just remember, if you know your pH, you know your CO2. The other thing is, if you see that little A right there, PaCO2, that little A stands for arterial. That little A stands for arterial. And you may take a blood gas interpretation where it just says PaCO2, same thing. Then you have your bicarbonate, which is 22 to 26. Now, the big thing when you start right here is start thinking of CO2 as an acid. Think of CO2 as acid. If you just write it down, because it will make your life so much simpler if you keep it what I call the KISS method, keep it simple, stupid. Is CO2 reflects carbonic acid. When you exhale, you blow off water and CO2, H2CO3, carbonic acid. Bicarb represents a base. Bicarb represents a base. So when you look over to regulation in the orange category or on your handout, that when we look at the PaCO2 or the bicarb, especially, we're looking at either, is this the problem, is this the disease, the imbalance, or is the other system compensating? Is the other system compensating? So when you talk about regulation or compensation, to me, God made a fantastic body able to compensate. And the first thing that will happen in acid-base imbalance is buffer systems will come to rescue. And they're like phosphate, proteins, okay. But the two most that we think about with regulation that you'll be tested the most on is whether it's respiratory or metabolic. And with respiratory problems, if it's compensation, this is a very fast system. And that means that it can restore pH in 5 minutes to a couple hours. So the respiratory system is fast to restore pH, but you can't hyperventilate forever, or you'll see somebody just have respiratory rest, and nobody should stop breathing to compensate. So it's a fast system, but not as effective as number 3, the kidneys. And the kidneys represent metabolic problems or compensation. And it is the best to maintain compensation, but it takes usually 2 to 3 days at least to bring pH back to normal. Now, the one thing people have trouble with the kidney that we're going to talk about is the blood gas. When you look at the blood gas, all we see is bicarbonate, which is a base. So you just got to think low base is acidotic and high base is alkalotic. But we'll give you some examples. But the kidney also regulates potassium, hydrogen ions, which are acid, but they don't show up on the blood gas. All right, so then for those of you, when you look at a blood gas, we have to look at the oxygen level, and it will have its own category. And we actually should looking at the patient's oxygen level first. The slide that we just looked at primarily is acid base. But when we look at the oxygen level, we need to know, is our patient on room air? And room air is 20 to 21%. That what we're breathing right now is about 21% oxygen. Now, if they're not on room air and they're on some O2 device like a Venturi or face mask, we need to know the percent of oxygen. We need to know the percent of oxygen to determine the severity of the condition. But on the other hand, before blood gas is drawn, we need to talk with the healthcare provider to see, do they want them on room air or oxygen? And if they have been on oxygen, we need to wait at least 15 minutes before the blood gas is done. Now, sometimes they can tolerate being without their oxygen, sometimes they cannot. So when you look at, and if they can't, then they have to go back on oxygen. Now, when you look at oxygen, my students tend to have the most trouble because I get them in the senior year. And so up to this point, they just look at acid base. So I have them starting to look at oxygen levels. So when you look at your oxygen level on the blood gas, you have PaO2 and your SaO2. And again, that little a stands for arterial. And many books sometimes just say PO2. I haven't seen anybody go SO2. They usually say SaO2. But that reflects arterial. Now, when you look at the PaO2, we have a large range, and it's 75 to 100. Some books say 80 to 100. But it is not till that PaO2 is 60 that we become hypoxic. It's not till we become hypoxic. And the SaO2 drops to 90, but you're going to hear me talk about that in a minute. Now, when you look at regulation of oxygen, O2 regulation, you look at the alveoli where diffusion occurs. You look at cardiac output. The heart has to pump the blood. Shock will alter it. But the most important thing when you look at oxygen delivery to the patient is the hemoglobin. And I just remember when I heard this, I was really shocked because the hemoglobin carries 97% of the oxygen. And the PaO2 is just dissolved oxygen in the blood. The hemoglobin, again, carries 97% of the oxygen on the hemoglobin, unless they get carbon monoxide poisoning, and then you get false readings. So the hemoglobin is very, very significant to oxygen delivery. Now, on the bottom of your slide, you're going to see something called the oxyhemoglobin dissociation curve. And this is significant when we look at hypoxia. And this is where we see the correlation between the SaO2 drops below 90, PaO drops below 60. And many of us get kind of immune to that low SaO2 because we have so many patients who have O2 sats of 86, 88, and they do just fine. However, not everybody does this. And this is considered hypoxia. And so when you triage in the emergency department, you need to look at the patient and intervene, see what is going on. So this particular book or slide, you see the oxygen curve. And I don't know if you can see me, but this book is critical care nursing, but you could pull this up, the oxygen hemoglobin curve, in any med surg book. What happens with this curve is that when the PO2 drops to 60, the O2 sat is less than 90. And so the hemoglobin becomes desaturated quickly at this mark. So just remember, when you have a PO2 of 60, which you have to get a blood gas, your O2 sat is 90. Now, on your next two slides, you're going to see something called, that talks about the oxygen hemoglobin curve. And you're going to see something shift to the right. And then the next slide, you're going to see shift to the left. Now, the only people that will probably have to know this is if you take CCRN or, well, emergency nursing. But when you are acidic or have fever, whatever type of acidosis, you have what is called a shift to the right. And it is much better to be a little acidic, because if you see in the box there, there's increased oxygen to the tissue, that the hemoglobin will let go of the oxygen so the tissue can absorb it. So it is a good thing not to be 6.8, but to be a little acidic. And then we have what is called shift to the left, which occurs primarily in alkalosis. And to be alkaline has a negative effect on the oxygen hemoglobin dissociation curve. And what happens when you're in alkalosis, whatever it is, you have decreased oxygen to the tissue. You have decreased oxygen to the tissue. The hemoglobin that's saturated with oxygen won't let go of it. It just stays there. And again, I hate to tell my age, but there was a time, if you were in metabolic acidosis or any acidosis, we used to push bicarb right at the beginning of the code. Okay. And we pushed it. Well, in about the 80s, late 80s, we found out about this. And I am an ACLS instructor, and I just was blown away. But now we do not give sodium bicarb unless they need it for metabolic acidosis. We do not give sodium bicarb unless it's metabolic acidosis or if they're getting a pH of less than 7.8 because of this condition. So question. What is SpO2? SpO2. Pulse oximetry. Okay. Well, again, I helped develop it. I wish I was, or I'd be a rich person. But SpO2, what we call the pulse ox, or what most doctors or nurses will call get an O2 sat. This is finger oximetry. And we first started using this in the late 80s. And whenever it was ordered, we had to do research to validate that the SpO2 was the same as an arterial blood gas. So there was a time that the SpO2 was just a new test. Now it is valid when you get, as long as they have perfusion. When you get an O2 sat, SpO2, it equals the SaO2, the blood gas. So I always tell students, I say, when a doctor says or the nurse says get an O2 sat, they do not mean a blood gas. But if you look in testing, When you see SpO2, that's the pulse oximeter. And SaO2, the little a, stands for arterial. So, like I said before, whenever the O2 sat drops below 90, you have hypoxia. And normal levels of O2 sat should be greater than 95. However, we're happy with a lot of patients if we just have 90 and above. But below 90, we need to really be investigating. And the blank that I have there is just to remind you, when you go to the blood gas, of the 90-60 correlation that the oxygen hemoglobin curve represents. And again, the O2 sat carries most oxygen to the tissue. So if you have somebody with a hemoglobin of 7 or 6 or 4, I've seen them 4, they are at risk for having a heart attack. So the next slide, which I think we answered that on page 1 of the handout, that I answered it there. But if you turn the page 2 of the handout, or we are on page 3 of the PowerPoint, that you see for ABG interpretation, acid balance, acid base, that we all have used or heard of, the acronym ROAM, to look at the relationship between pH and PaCO2 and bicarb. Now, there are some people that use the tic-tac-toe, but, I mean, I'm telling you, I've been in critical care for a long time, and every time I used to even write for emergency nursing and critical care, but now I just take the test. And the acronym ROAM helps keep it simple. So when you look at the PaCO2, it represents respiratory conditions or respiratory compensation. And the pH will be opposite. The pH will be opposite of the PaCO2. So if the PaCO2 is high, it's an acid. Think PaCO2 is high, the pH will be low, acidosis. Metabolic, again, represents kidney function, kidney problems, metabolic problems, and bicarb is a base. And when you look at the blood gas, if the bicarb is high, HCO3, the pH will be high. And that's really something. If the bicarb is low, the pH will be low. Metabolic acidosis. So especially when we start looking at mixed blood gases, combination or compensation, you really have to remember PaCO2 is an. Whenever I exhale, I blow off water and CO2, which is H2CO3. Water and CO2. And so this slide just talks about, again, when you interpret acid base, the only 3 values you need to look at is number 1, the pH. That's the first step. The first step is to look at that pH. Is it high or is it low? And then you look at respiratory, CO2. And it is either a respiratory problem or the respiratory system has come to the rescue of a metabolic problem. And then we have our bicarb. 22 to 26 represents metabolic problems. kidney problems. So it's either the problem or compensation. So there you go, respiratory, metabolic. So on your blood gas right here, we're going to do some interpretation near the end of the PowerPoint. Again, there you see PaO2, arterial, and here I put 80 to 100. Some hospitals, again, say 75 to 100. Some say 80 to 100. But you are not clinically hypoxic till 60. There you see SO2, you're hypoxic at 90. And room air, as we talked about that we're breathing right now, our room air is 21%. And just remember, SpO2 pulse oximetry equals SaO2. Now, real important is the concept of O2 toxicity, oxygen toxicity. Oxygen toxicity. We do not want 5 patients of oxygen if they need it, if they're hypoxic. But if the FiO2, which we call fraction of inspired oxygen, it's just the oxygen we're delivering, fraction of inspired oxygen, is greater than 50% for 24 hours, this sets up for ARDS, acute respiratory dysfunction syndrome, that we used to call it just for adults, but now we see it with babies. We first found out about the dangers of high oxygen in the Vietnam War with the young soldiers who were in MASH units who became septic. Back in those days, students always, you never wore gloves? No, I never wore gloves. In Athens and whatever, I've been covered in blood. I didn't have to wear gloves till 1988 in the hospital. When I did dialysis, I had to. But what happened with the soldiers in Vietnam, which can happen in Afghanistan, every war we learn something, is that those soldiers were saved by those surgeons and nurses. But they were given high percent of oxygen. And a week later, this healthy young soldier died of respiratory disease. So we have learned over the years that oxygen is toxic. So if at all possible, we try to lower it. Now, there are some who will say 50 to 60%, 48 hours. And this is especially hard on ventilator patients. But we do have to remember that whenever we go over 50% for 24 hours, we increase the chance of ARDS, acute respiratory dysfunction syndrome. Now, compensation, if you go to, I believe I have it started on page 2 and 3 of the handout. Number C there, you see. But compensation, the whole purpose of compensation is to restore the pH back to normal. It does not correct the imbalance. It just brings the pH back to normal. And if they're acidic, it brings it just right back to like 7.35 or 7.36. If they're alkaline, it will bring it back to like 7.4. And I always equate it like when you're giving somebody, your child, a bath, and the water's too hot, you turn the cold on. So the body is like that. As soon as the pH gets out of this range, the other system comes to the rescue. So remember, compensation does not correct the imbalance. It just puts the pH into, like Goldilocks said, just right. And I remember a girl in Atlanta had too much fun at one party, and her pH got down to 6.9. But because she was young, she made it. But this is what compensation. But you get a pH of 6.8 to 7.8, that's considered lethal. But we try not to get that low. 6.8 to 7.8. If you go past that, you're not supposed to live. So right here, we look at compensation. The respiratory system, like we talked about, is the quickest, minutes to hours. But all of you know people who are breathing, and they'll wear out. So the respiratory system is a fast system, but it is not good for long periods of time. Where the renal system, represented by your bicarb, is the best. The kidneys are the best regulator of acid base, but they take time to hold on to bicarb or excrete bicarb, which we see on the blood gas. But remember, the kidneys also regulate hydrogen ions, which are an acid. But all we see on the blood gas is bicarbonate, which is a base. Now, when you look at compensation, there are really three types of compensation that you can see. First of all, there's no compensation. It's what we call a pure blood gas. The pH is low and the bicarb is low, and the respiratory system is not compensating. So again, with no compensation, there will just be two abnormal levels, the pH and whatever's causing the problem. With partial compensation, all three values will be abnormal. Partial compensation, all three values will be altered. The pH will be high or low, the bicarb or the CO2 will be high or low, and then the other system will compensate in the same direction, You hear that, same direction. And in a minute, you're going to see that when you compensate, partial or decompensation, if the CO2 is high, which is an acid, the bicarb will be high. It always, when you see two going the same direction, not the pH, but when you see the CO2 and the bicarbonate going in the same direction, one of them is compensating and one of them is the problem. Then the third type of compensation is full compensation. And some will call it, they may not even say full, they may say compensated, but most sources that I see and will call it fully compensated. And you know it's fully compensated if the pH is back to normal. That if it was acidic, it now is 7.35 or 7.36. It doesn't go all the way to 7.45. It just gets into range. But with fully compensation, the pH is normal, but the other two values are abnormal, like partial, and they move in the same direction. So the only difference between partial and full is that the pH is normal. The compensatory mechanism has fully compensated, got the pH back into that just right. It's just like when you put your foot in a hot bath and you go, ooh, and well, you don't say that, I imagine, but you put cold water in there so you can put your foot back in there. So now we're going to look at some arterial blood gases. And what we're going to look at here is I'm going to have you determine what the acid-base imbalance is, what is the oxygen status, and then look at the compensation. What type of compensation is occurring? None, partial, or full? Oh, I think I corrected on yours, but number 4 is the etiology or cause. Yep, I fixed it on yours. 4, etiology, and 5 is management. That we're going to see what management we're going to do for each of these. So, let's give it a shot here. So if you have that right there, we're at the top of page 5 of the PowerPoint, top of page 5 of PowerPoint. And the handout I'll explain to you goes more and more into compensation and gives you examples. So the first thing, look at a blood gas. You really should look at the oxygen level, and that is represented by the PaO2 and the SaO2. And as you see in yellow, when you see the PaO2 of 50 and the O2 sat of 80, you need to do something. This person needs some oxygen. And do not get confused between the PaO2 or O2 sat. Before I taught at ABAC, I taught at Valdosta State and Georgia College. And I remember having a student at Georgia had a post-op patient, a young guy who was getting PCA morphine. And his O2 sat was 86. Well, he got confused between O2 sat and PaO2. Okay, an O2 sat of 80 is life-threatening. You do something. And so, but again, what was he looking at was the O2 or the SpO2. The SpO2 was sitting there on the, he had continuous pulse ox. He didn't have a continuous blood gas. But he did get a blood gas, and we discontinued his morphine. The next thing you want to look at is your pH, And this is where the arrows can really come in handy when we talk about Rome. I really like for you to mark it because when you write it and you're taking a test, you can forget. But when the pH is low, you're acidic, less than 7.35. And if we remember Rome, PaCO2 is an acid. So Rome, respiratory, opposite. So as soon as you see an inverse relationship between the pH and the CO2, you have respiratory acidosis. And that's why I have the two together. That is the problem. Now you go, well, the bicarb is high. The bicarb is high. But bicarb is a base. Bicarb is a base. And whether you remember metabolic equal or not, if this is a metabolic problem, the pH would have to be high. But there is no way in this world a bicarb a high base can cause acidosis. There's just no way. And so another cheap thing to remember is when the CO2 and bicarb are going in the same direction, you have compensation. The trick is seeing which of the two could cause acidosis. And CO2 is an acid. So when we look at the blood gas then, we have hypoxia, which we need to do something about, respiratory acidosis, because pH is less than 7.35, and we say partial compensation because the bicarb, the kidneys are holding on to base in an attempt to get that pH back to the just right, just wanting to get the pH back to within normal limits. It's like putting your foot in a hot bathtub. You put on the cold water. So bicarb is being retained by the kidney. The other thing, when you look at bicarb, for it to be 34, this has probably taken a day or two. This has probably taken a day or two because the kidneys take at least a day to 2 days to compensate. So this is not a new condition. This may be somebody on the ventilator or having respiratory issues. Okay. Now, when you look at the etiology, whenever you see a high CO2 or PaCO2, you got respiratory problems. You got respiratory problems. And so a lot of times with breathing, when I talk to students, because again, I get them in the senior level, they always think respiratory acidosis is caused by somebody breathing slow. Well, it can be. If you overdose on fentanyl, or they give you 100 of Dilaudid, that D word that everybody can't say, but they all want it. If you give somebody enough opiates or benzodiazepines, you will cause the breathing to go slow, and yes, they will develop respiratory acidosis. But usually slow respirations we can reverse with Narcan or Valium, and they'll come back. On the other hand, the most common probably that I see, and that scares me the most, is somebody breathing fast and shallow. Fast and shallow. Fast and shallow. They might be breathing 30 breaths a minute, but they're in pulmonary edema, or they're having an asthmatic attack, or they're in ARDS. Whatever the case is, they're breathing shallow and fast, but there's no diffusion. CO2 is staying in the body. So whenever you see somebody breathing fast and their CO2 is high, they've got some sort of respiratory problem. I had a girl, she had a thyroidectomy, and she was a smoker. And we actually held her neck so she could cough up all the secretions. So as soon as you see a CO2 elevated, you need to automatically start deep breathing and coughing, use the spirometer, because if you don't watch it or they don't get that CO2 up, they're going to end up on the ventilator. So when you see an elevated CO2, we want to increase ventilation, versus when you see a low O2, we want to increase O2 delivery. Want to increase O2 delivery. And in this case, we would want to give a non-rebreather possibly for a while till we see what's going on. Having a bronchospasm, what's going on? This could also be late ARDS, where they become hypoxic. We want to work on ventilation. And so our respiratory therapists and healthcare provider have lots of different treatment, albuterol, but whatever, we want to get that oxygen up first and then work on getting that CO2 out of there. So like our COPD patient, we'll do pursed lip breathing, pursed lip to prolong expiration, blow it off. So whenever you see high CO2, you want to get that CO2 out. And we don't want to give sodium bicarb unless the pH really drops below 7, because we remember the oxygen hemoglobin dissociation curve. Just don't give sodium bicarb like we used to. All right, the second blood gas that we see here, again, you can take just a minute to see if you can do what you think is the pH. Is it high, normal, low? Is the CO2 high or low? Is the bicarb high or low? And you can start making these arrows. And these arrows are used in text, like in this critical care text. I mean, nurses have so much information in their heads. We need all the little crutches we can get. But when you first look at this blood gas, again, you should look at the oxygen level first. And so you see a PaO2 of 88 and an SaO2 of 96 is normal. But when you look at this one, you see the pH is 7.35, so it is normal, but it is on the low normal. It is on the low normal, so we treat it as acidosis. So anything below 7.4, we consider towards the acid side, and anything greater than 7.4, we consider towards the alkaline. So in this case, you see somebody is in metabolic acidosis that you see right here, and I just found something wrong. Let me make sure it's on your sheet. Yeah, you have it correct. You have where you see your bicarb says 16. Let me fix that. So when you see this, when you see your metabolic acidosis, let me go. And you may not have even, because your slide says correctly, but when you see this condition, the bicarb is low. You do not have enough base. And your CO2 is low, so you are blowing off acid. You are blowing off acid. And that PaCO2, blowing it off, has brought pH back to within normal limits. And many of you are familiar with the breathing pattern called Kussmaul respirations, rapid and deep respirations that we see with our diabetic patients and acute kidney injury. So when you look at this right here for the blood gas, this is metabolic acidosis. Metabolic acidosis. And we call it full compensation or complete compensation because the pH is back to normal. Okay, but it is in the low end of normal. And the nice thing about metabolic conditions, when all the values are going the same direction, it is metabolic. And again, you see the CO2 is low and the bicarb is low. So when you talk about the etiology here for metabolic acidosis, the cause of it can be acute kidney injury, which is a new term, acute kidney injury, the new term for renal failure, acute renal failure. Any dialysis nurse, you all do dialysis and spinal cord injury patients down there. So that's chronic. But in acute kidney injury, whenever you have an acute change in your pH, this other system comes to the rescue. You may not see this in chronic kidney disease where the hyperventilation occurs, but in acute kidney injury. Then you have metabolic acidosis and diarrhea. Where you see etiology, you see diarrhea. And when you have diarrhea, you lose base. You lose base and potassium. Plus it's code brown, but anyway. But if you have emesis or vomit, you lose hydrochloric acid. But when you have diarrhea, the pH of the GI tract changes at the duodenum, where the pancreatic enzymes come in and the bile comes in, and so you lose base. And I would just also have you circle that diarrhea is the only one of the rare cases of metabolic acidosis where your potassium will be low. Diarrhea is one of the few times that your potassium will be low. Any loss, you lose potassium. But in 99% of the time, when you have metabolic acidosis, you have high potassium levels. And then we have DKA, diabetic ketoacidosis, where we hold on to fatty acids, acetones, and we go into acidosis. And so Kussmaul respirations, those deep, rapid respirations to blow off the CO2. Now, I don't know if you've ever taken care of somebody who is in DKA, who's not been diagnosed. Like they'll say, well, I didn't know my sugar was a problem. They don't have any ID on them that they're diabetic. They're usually young. They've had a virus or something, and they come in with a blood sugar of 600 or 500 or 400. But what they can be doing when they have Kussmaul respirations and high glucose is they act incoherent. They act like they're having an anxiety attack. They act crazy. And occasionally there have been cases where somebody in DKA or metabolic acidosis who was hyperventilating to compensate, to get the CO2 off, were given a brown paper bag, which killed them. So you never want to give a brown paper bag to anybody unless you're sure it's respiratory alkalosis. Because whenever you blow into a brown paper bag, you're holding on to CO2. So when we look at the management of metabolic acidosis, we need to treat the cause. We need to treat the cause. So acute kidney injury, usually their potassium is high and they get put on dialysis. And I did acute dialysis back in '82 when it first came out. And so again, or they can go into severe pulmonary edema, but it's that potassium that's going to kill them. And then we put them on dialysis. But diarrhea is one that they have a low potassium. And then DKA, we treat them with insulin infusions and monitor their potassium very closely. Because in DKA, the potassium will be high, and as the glucose is corrected and the acid base is corrected, the potassium can just drop. So we have to be very careful with potassium levels when we treat somebody in DKA. All right, when we look at this one, number 3, at the bottom of page 5. And again, the first thing we should look at is our oxygen level. And so you see you have a PaO2 of 55 and an O2 sat of 80. So this again is hypoxic. Okay. Hypoxic. And then when we look at our pH, when you look at your pH, you see the pH is high, and you see the CO2 is low. And let's see, this is number 3. Gosh, I did this last night in the middle of the night. You have 30 and 20, but that's not going to be any difference. But your pH is high and your CO2 is low. Your alkaline, right here, your pH is low and your base is low. And when you see the pH high and CO2 is low, you know Rome, respiratory opposite, and bicarb is a base. So the body is getting rid of base. The body is getting rid of base because we're already alkaline. And again, you see both moving in the same direction. You just have to look first at the pH. Is it alkalosis? Is it alkalosis? Yes, it is greater than 7.45. Then you have to look at your CO2, your PaCO2, and your bicarb. Which of those could cause alkalosis? A low CO2, because a normal CO2 should be 35 to 45. And then your respiratory, your bicarb is 20, getting rid of base. So when you look at your ABG, you are hypoxic and you are in respiratory alkalosis. Respiratory alkalosis. with partial compensation. When you see a low CO2 like that at 28, this person's lungs are working right now. Because when you hyperventilate, that's what will happen. Your CO2 will be low. And you think, well, how'd they get hypoxic? Well, this can be a common blood gas with somebody initially who has possibly pulmonary embolus or ARDS. Early ARDS can have somebody hyperventilating. But when you see this hypoxia, despite oxygen, this makes you think ARDS may be developing. Early ARDS. Eventually, the surfactant, the alveoli stops making surfactant, and then they go into respiratory acidosis. So it's only a short time that they'll stay in this respiratory alkalosis. Versus if we took the PaO2 away from it, like we said, the PaO2 was normal, and the SaO2 was normal, you could see this breathing pattern in somebody having an anxiety attack, somebody in labor, somebody having a fever, somebody in pain, burns. Okay. But when you throw in this oxygen, the low oxygen, this makes me think of early ARDS. And it's not going to take long till this condition is going to go into respiratory acidosis. So management here is going to increase O2 because your O2 sat and your PaO2. Treat whatever's causing the problem. Normally, we should not see the abnormal oxygen. And then we need to decrease the respiratory rate. We need to decrease the respiratory rate with some midazolam, some Deprivan. This might be somebody on the ventilator. But whatever, they're scared. They need some medication to calm them down. Have a family member come hold their hand. Whatever, we need to decrease the respiratory rate. And again, with respiratory alkalosis, of course, we're not going to give sodium bicarb. They're already alkaline. But the arrow going up, alkalosis, pH. The pH is high, the CO2 low, and the bicarb is low. Then we go to the fourth blood gas right here. Which is the top of page 6. And when we first look at it, we see our PaO2 is 85 and our O2 sat is 96. So our oxygen is okay. So that's a good thing. Now when we look at our pH, we see it is normal. But it is on the high normal. So we treat it as alkaline. An alkaline. So you're going to see right here, okay, that you see the pH is going to be high. And then if you keep it simple, stupid, which if you have as much stuff in your brain as I do mine, with all the things that come at us nurses, that when all values are going up, whether you know anything at all, it is metabolic. Now, a friend of mine who I taught with, she goes, you just can't be teaching them the arrows. And I go, well, I'm not just teaching them the arrows. I am just saying it helps you gather your thoughts. But if they're all moving in the same direction, it is a metabolic condition. And if they're all going low, it's metabolic acidosis. Now, in this case, when you see that it is slightly alkaline, even though that 7.45 is what? Within normal limits. It's normal. But the reason we're alkaline is because we have a high base. We have a high base. Normal base is 22 to 26. Now your CO2 is 48. So normal CO2 is 35 to 45. Normal CO2 is 35 to 45. So your pH here is high. You're holding on to a little bit of CO2. You're breathing a little bit slower to bring that pH back into normal. That when you see that 48, normal pH CO2 is 35 to 45. We're breathing just a little bit slower, and that pH, that CO2 is 48. So when we look at this blood gas right here, we call it metabolic alkalosis fully compensated, because that pH has been brought into normal limits. So it's normal. I'm putting the arrow there just to help you understand when you look at a blood gas, it will be close to the alkaline side or the acidic side. It doesn't swing all the way to the other. But 7.45 is normal. So this is fully compensated because of the bicarb. Remember, bicarb is a base. CO2 is an acid. There's no way a high CO2 could cause alkalosis. We know it's compensating to get that pH to just right. So when you look at the etiology of metabolic alkalosis, if you can think of what causes metabolic acidosis, it can be just the opposite of it. So right here, what we see probably the most common is diuretics, potassium-losing diuretics like furosemide or hydrochlorothiazide. But your potassium-losing diuretics, you lose potassium. And then the next common cause, unless you live in Afghanistan or somewhere where we don't have diuretics, the most common cause in third world countries would be vomiting, because they don't have renal disease, or if they do, there's no diuretics. But upper GI loss, you will lose hydrochloric acid and you go into alkalosis. So with metabolic alkalosis, the most common in the United States is everybody almost is on Lasix, and they have to have potassium. And when I graduated in Birmingham, everybody had Lasix, everybody had potassium. Their horse pill that they called it in, and I still hear them call that horse pill to get their potassium in it. or they're bananas. So when you look at management for metabolic alkalosis, is potassium protocol, like K rider, because usually why they're alkalotic is they have lost potassium. Potassium is acidic. Anybody who knows somebody who's gotten a high potassium fluid knows that it will burn. And that we have to give high doses in ICU. That you should not give more than 10 milliequivalents an hour. But in ICU, you can give 20 or 30, depending on your protocol. The potassium IV that we're going to give. We had a girl, she had an emergency hysterectomy. She had triplets and lost her uterus. And she had a potassium of 2.2. And so the doctor and I, we tried to give her 20 milliequivalents per peripheral line, even 30. But then, because she was too brittle to put a central line at that time. But again, potassium, when you give it, is very caustic, and you must follow your protocol, because on the floor, max amount of potassium you can give in most hospitals is 10 milliequivalents in an hour. And they should be on telemetry when you give potassium. But again, always check out your protocol. Now, I want to tell you that one of my bridge students, she's an LPN, and now she's graduated. The doctor overdosed somebody with PO potassium. I've never heard of that before. That he ordered so much potassium PO that the patient nearly died. Which is, he got his orders. I guess that's just usually not seen, but it did happen, and the potassium went low to very high. So we have to keep a very close eye on potassium. All right, and our fifth blood gas that we have here is that we look first at our PaO2 and our O2 sat, and we see that's normal. So now if you're looking at your pH, you see your pH is low. So it's acidic. And your PaCO2 is high. Represents carbonic acid. And then your bicarb is low. Normal bicarb is 22 to 26. So when you look at this blood gas, that this is not compensation. This is not compensation. Because it's real evident, the first one, Rome, respiratory opposite. But if the kidneys were going to compensate to get that pH back into normal, the bicarb would have to be elevated. And in this case, right here, darn it, you have it right on this one, just didn't correct it here. That you see your bicarb is 16. Which you have on your handout. So you have respiratory acidosis and metabolic acidosis. The pH is low, acidosis, and your CO2 is high, and your bicarb is low. So whenever you see the two values going in opposite direction, you have what is called a mixed blood gas. And you see the metabolic equal and the PaCO2 roam. So when you look at the etiology, we've already covered it. It could be respiratory disease, in metabolic acidosis, acute kidney injury, DKA, and diarrhea, where you lose base. And again, diarrhea is one of the rare cases of metabolic acidosis where you also have low potassium. When you think metabolic acidosis, you should think hyperkalemia. So management for this condition, or if you look at breathing pattern, again, for respiratory acidosis, it could be fast or slow. Fast or slow. Okay, because this person is in two blood gases, there's no compensation. So you have two conditions going here. You might have somebody in acute respiratory failure and acute kidney injury. So you've got two disorders going on. Or you could have somebody in pulmonary edema with that CO2 elevated and the bicarb representing acute kidney injury. So your breathing could be fast or slow. Or they could have just overdosed on fentanyl and have diarrhea. But whatever, when you see a high CO2, it can be from slow breathing with normal lungs or fast with diseased lungs. When you see a high CO2, like 63, they could be breathing fast if they have diseased lungs, or they could be breathing slow if they just took too many opiates. So management here is to treat the cause and increase ventilation. Whenever you see a high CO2, we want to get ventilation better. Deep breathing, cough, pursed lip breathing for the COPD patient. When you think CO2, increase ventilation. But our PaO2, where our oxygen status is fine. And lastly, we're getting pretty glad that research that I've reviewed, because what I had to do for this presentation is I had to take a lot of different PowerPoints and put it all into one. And but what they're finding for practicing nurses to have independent modules for reinforcement. I always say if you don't use it, you lose it, and it's something that you have to do periodically. And so there can be modules that you do for blood administration, or however your hospital is doing it, like on the web, or there can be a take-home module. But what they're finding, because blood gases, nurses are hit with so many different things, and they've got to do it. Some catch on to this easier than others. If you just worked all night, you probably are too tired, or whatever. But they say the modules are the best. The other thing is when you have a knowledgeable staff, you have better outcomes. And if you go on to get certifications, whether it's nurse practitioner or med-surg specialist or CCRN or CEN. If you want to work at a big teaching hospital, I know Navicent, want you to be certified. In fact, one of our flight nurses, for her to work at a level 1, she had to get certified. So many of these facilities are wanting their nurses to be certified because it keeps you on top of things. And then another best practice for blood gas is collaborative rounds with healthcare providers who are knowledgeable about blood gas. And then the last one, arterial lines, where frequent ABGs are done, are linked to better patient satisfaction scores. So there's a need to put arterial lines to get blood gases in earlier than later. And so I know Tifton has just beefed it up to get arterial lines in as soon as possible on their acute patients versus waiting. Patients do not like getting blood gases. And I did this probably more for myself because it was a long weekend for me. This actually was from, I've also been a ATI reviewer, NCLEX, and PESI. And so we all have to be positive and yourself and stop complaining and smile. And when somebody smiles at you, you really do feel better. And a lot of our nurses, student nurses, sometimes they think nurses are mean. I say they're not mean. They're just tired. And I just want to tell you, being a nurse since 1975, Lord have mercy, we get all sorts of things thrown at us. And but at least we're not at bed and not on the ventilator. And so, but just remember to stop complaining. Some people spend so much time complaining, they just would do it. And then if you have any questions at all, feel free to email me, or probably the best thing. But, if you have any questions. The other thing I wanted to tell you on the back of your handout, the one, if you look to page 6 through 8, there are some questions and the key that are attached. And so in preparing for this, because I do teach the critical care, I did look at like American Journal of Nursing and some other sources up there on the web. And so they're asking the same questions. So if you work a med-surg unit, which I bring students to the med-surg unit, our patients are sick. They're like step-down patients used to be. So anyway, there's some questions there that you can use, and then you can read some of that. And I guess, do you all have any questions at all? But I think that best is if you can get some interpretations. But the Rome will work. But remember, when both the CO2 and the bicarb are moving in the same direction, there is compensation. If they do not move in the same direction, you have a mixed blood gas. So you've got to remember that CO2 is an acid and bicarb is a base, and apply it. But the little arrows will help you. So last, like I've seen or people have said, the manager asked me what this blood gas was, and they put my brain on the spot. And this paramedic, we have a lot of paramedics in our program, And so he quickly just wrote the arrows and it came back to him. So, does anybody have any more questions at all? Or I guess that will be it. And I guess it's raining down there. It's raining here. Does anybody have any questions at all?
No, ma'am.
All right. Well, thank y'all for letting us come into your hospital. And again, I've worked a small hospital, and people don't know all the stuff that you have to. And all hospitals, what nurses do. So I guess that will conclude this presentation. Thank you.
Thank you.